Good morning and a very, very warm welcome to this year's ICENTD Climate and Health Conference. It's our third annual event that looks at the linkages between climate and health with a focus on diseases and particularly through the lens of neglected tropical diseases and the communities they most affect. For those new to our events, I'm Marianne Comparet from the International Society for Neglected Tropical Diseases, and it's really my pleasure to welcome you today to this meeting, packed with presentations and discussions across the day on climate and health, and with insights really from a very wide range of tropical disease cross-cutting research from around the world, stakeholders working across the healthcare sector, data and modeling, but also touching on the fields of soil health, mental health, and many more topics, which will give us a very comprehensive view of how climate impacts infectious diseases, but also how the evidence base, the research itself in this field is building up. So WHO itself has stated that climate change is the single biggest threat to human health of the 21st century, and that really spans across both the immediate threat from climate events, but also the increasing risk of emerging diseases. Health indicators can really provide a robust benchmark against which to measure both the real impact, but also any progress made in reducing the impact of climate change on human life. So if anything, these collaborations will foster better quality information and data to support decision-making, negotiations, and also the mitigation of present and future risks. And so it's in this light and with kind of this background that I'm really delighted to open this day with our first session right now, looking at the journey from data all the way to informing disease control and policy. I will hand over to one of the most exciting teams working across climate and health, based in Barcelona at Barcelona's Supercomputing Center, and working on a lot of data modeling, but also really with a very concrete aim to inform disease control policy making. Hello, everyone. We are joined by our colleagues who will be taking us through some of the most exciting, really, programs and projects and modeling around numerous different diseases and particularly tropical diseases. And I'm just going to go around the screen as everyone's appearing on mine. Welcome to Dr. Bruno Carvalho. Bruno, you are a recognized researcher at the Global Health Resilience Group. Thank you for being with us this morning.
Thank you, my pleasure.
Thank you. We're also joined by Dr. Kim van Daalen, who will be talking to us about the Lancet Countdown initiative, the Lancet Countdown on Health and Climate Change in Europe. Hello, Kim.
Hi, so nice to be here.
Thanks for joining us. Dr. Giovanale Moirano, you are visiting research fellow at the Global Health Resilience Group. Nice to see you.
Hi, everybody. Nice to be here.
And Dr. Rafael Saldana, you are postdoctoral researcher at the Institut National de Recherche en Sciences et Technologies du Numérique, based in Montpellier, I believe.
Right, that's it.
Yeah.
Thank you very much.
Nice to have you here. And Chloe Fletcher, welcome. You are a PhD student in climate change epidemiology at the Global Health Resilience Group at Barcelona Supercomputing Center as well. Nice to see you, Chloe. Well, thank you very much for being here. You're going to be talking to us about data and modeling tools for climate-sensitive health outcomes. And without any further delay, I will hand over to you, Bruno. Thank you to the team for being here. And for anyone who's tuning in live, please, I always say this, don't hesitate to say hello in the chat. Tell us where you're connecting from, and also any questions you may have that arise over the next 45 to 60 minutes for our panelists. Please don't hesitate to post them. We'll be taking questions and having a nice discussion after the presentations. Thank you for being here, and over to you, Bruno.
Thank you very much, Marianne. I hope you can all hear me well. It's a pleasure to be here and representing the whole group. I might share my screen. Okay, thank you. So this is a very brief introduction to our group at the Barcelona Supercomputing Center. First of all, I would like to thank the organizers and Marianne for inviting us. It's a pleasure to be here and to be talking about some of our different projects. So we built up this session called the Data and Modeling Tools for Climate-Sensitive Health Outcomes. And a little bit about our group. We are a fairly recent group at the Barcelona Supercomputing Center, and our main mission is to co-design policy-relevant decision support tools to enhance surveillance, preparedness, and response to global health challenges, with a focus on climate-sensitive infectious diseases. So we are an interdisciplinary team of researchers at different levels, so postdocs, PhD students, and software engineers and data scientists. We conduct cutting-edge methodological research to understand the links between environmental change, socioeconomic inequities, and infectious disease emergence and spread from global to local scales. We co-create indicators, impact-based forecasting models, and early warning systems at sub-seasonal to decadal timescales to help anticipate future risk in collaboration with public health, disaster risk management, and humanitarian agencies. So this is an outline of our this morning session. Thank you, Marianne, for already giving a nice introduction about us all. So we're gonna start with Dr. Kim van Daalen, which is a postdoctoral researcher at our group, talking about the Lancet countdown in Europe. And following Kim, I will be speaking a little bit more about one of the indicators that we developed for this same report for the Lancet countdown, which is focused on Leishmaniasis in Europe. After my presentation, you're having Dr. Giovanale Moirano, which is a visiting researcher here, talking about a modeling study on West Nile virus in Europe. And after Giovanale, you have a nice presentation from Rafael Saldanha, which is a postdoctoral researcher at India and a close collaborator in different projects of our group. He's going to be talking about data fusion of the disease and climate data for modeling in Brazil. And then last but not least, you're going to hear an amazing talk by our PhD student, Chloe Fletcher, on the current project that we are working to forecast infectious disease outbreak across Latin America and the Caribbean in response to the current El Nino event. So before I hand over to Kim, I just have this final last slide to tell you that we are currently recruiting different posts into different positions for our group. So feel free to follow us and browse the different opportunities at the BSC website. We are led by the ICRE research professor Rachel Lowe, and also feel free to follow her on Twitter, on X, as she is always sharing news about our group and then the open positions as well. All right, so this is my last slide for the moment, and I'm gonna hand over to Kim.
Yeah, thank you so much for inviting us to speak here today. I'm very happy to present some of the work that we're doing with the Lancet countdown in Europe. Next slide. So all of us know that our climate has been changing, and climate and environment has always been impacting our health. But at the moment, climate is changing more rapidly and more frequently than before, and that is impacting our health. Next slide. But it is not just one aspect of human health that climate change is impacting. It is impacting things as undernutrition, it is impacting our health, cardiovascular disease, respiratory disease, but also different infectious diseases. So within the Lancet countdown in Europe, our work is focusing on this whole broad spectrum of health effects. So we'll first focus a little bit on that, and then I will zoom in one of our indicators that is focusing on vector-borne diseases specifically. Next slide. A lot of these impacts that we're seeing of climate change on human health are often unequal, disproportionately impacting populations who have contributed the least to the problem. And this is often due to differences in people's exposure to climate hazards, as well as differences in susceptibility to the damages caused by climate hazards, as well as people's ability to cope with or recover from the damages caused by climate hazards. And this results in disproportionate impacts on human health across populations. Next slide. So in 2009, one of the flagship publications on climate change and health was published, which summarized all of the different aspects that human health is impacted by climate change, calling climate change the biggest global health threat of the 21st century. And then a few years later, in 2015, the first Lancet Countdown publication was published. And this is a collaboration of researchers that are tracking all the different ways that climate change is impacting human health, as well as how climate mitigation, so trying to prevent further climate change, and climate adaptation, adapting to current climate change, may have health co-benefits, so positive impacts on human health because we increase active transport or have healthier diets. Next slide. So we have been moving from seeing it only as a threat to also seeing it as one of the biggest global health opportunities of the 21st century to climate action. Next slide. A lot of the work that we've been doing has initially been focusing on the global world, so all of the world. But at the moment, we are developing different regional centers, and these different regional centers are able to focus on specific climate change and health risks that are relevant for a specific region, as well as being able to use data that is more regionally appropriate, or for example, at a finer level. So for example, in Europe, we're often able to look at gridded data or NUTS 2 data or NUTS 3 level data, which is a finer scale data than in other regions in the world. Next slide. So the first indicator report was published last year, which included 33 different indicators that track climate change and health across 5 different domains. So the first domain focuses on impacts, exposures, and vulnerabilities. This includes indicators that look at climate-sensitive infectious diseases, as well as things as heat-related mortality or the impact of heat on physical exercise. Then we have another working group or another team that is focusing specifically on adaptation and planning. Then we have another team that is focusing more on mitigation. So for example, how we see a reduction in deaths related to air pollution because we are trying to reduce greenhouse gas emissions. Then we have a 4th team that is focusing on the economic impacts of climate change on human health. And then we have a 5th team that is focusing on how different actors engage with climate change and health. So for example, governments as well as healthcare professionals, etc. Next slide. So I talked a little bit about indicators. So what do I mean with indicators? Next slide. Indicators in our report track an aspect of climate change and health that needs to be relevant and meaningful for policymakers or for the broader scientific fields. They of course need to be scientifically sound and reproducible, temporarily representative. So most of our indicators at the moment go back in time. So they start somewhere in the 1950s and then they track climate change and health up to a date as recent in the present as possible. So for our next report, it is, for example, 2023. They need to be geographically representative. In our collaboration, where we focus on Europe, we focus on all the 53 different World Health Organization Europe countries and Liechtenstein and Kosovo. And they need to be based on reliable and updatable data sources. So for a lot of our indicators, that means that we use publicly available data or climate reanalysis data, and those are combined into different exposure response models to create the different indicators that we have in your report. Next slide. So I cannot go through all of our 33 different indicators, but I will show you this slide as an example of what the overall results show. So when you look at the top of this graph, we see climate-related impact indicators, and at the bottom, we see climate response indicators. And in this figures, I have standardized them so that we can see overall what the trends are. And what we see is that there are accelerating trends in health-related hazards, exposures, and vulnerabilities from the risks of climate change, and that there's a lack of sufficiently ambitious adaptation and mitigation strategies. So in the top, we indeed see that it gets darker and darker, it gets more and more red. And at the bottom, we see that there is some improvement. There's some more blue coloring, for example, when we look at premature mortality related to air pollution, but things are still far from where we want adaptation and mitigation to be. Next slide. A lot of the work that we are doing is also in direct collaboration with European partners. So we are part of the European Climate and Health Observatory, which is aiming to provide governments with information on how to adapt to the health impacts of climate change. And if you go to their portal, you can find different of our indicators as interactive visualizations. So there you can find what specific impacts of health and climate change are on a region that is of relevance for you for a specific time period, etc. Next slide. Next to that, a lot of our work also directly contributes to different policy reports where we highlight some of the science as well as some of the actions that should come forward out that. And we have just submitted last week our next reporting cycle, which this time includes 42 different indicators generated by 67 different authors. We are also updating new visualizations in the platform that I just mentioned. But something that is quite exciting, I think, about our next report is that we try to focus more on equity and justice and highlight which are the vulnerable groups that are most impacted by the different effects of climate change that we're tracking in our report. Next slide. I will just highlight one of the indicators was just highlighted by Bruno, just to show what kind of infectious diseases indicators we have. So for our next reporting cycle, we track non-cholera Vibrio, West Nile virus, dengue, chikungunya, and Zika, malaria, Leishmaniasis, and ticks. And I will just present some of the data that we had in our previous reporting cycle on dengue. Next slide. So this is to give you an example next to Bruno's example of what an indicator looks like. So this indicator is part of has two parts. The first part is a mechanistic model that estimates the basic reproduction number for dengue, which is combining information on temperature, rainfall, mosquito abundance, and human population density. And then the second part of the indicator estimates the annual number of people that are infected with dengue that move from a dengue endemic region around the world into locations in Europe where conditions are suitable for dengue transmission. Next slide. So when we look at this figure, when we look at the left axis, we see the estimated R0, and at the right axis, we see the relative change in imports of dengue cases to dengue suitable NOTS 3 level regions. And then overall, we see that the basic reproduction number in all European regions has increased when we compare the first part of the data set with the second part of the data set, with an overall increase of 17.3%. And when we look at the second part of the indicator, which is the black line on this figure, we see that between 1990 and 2019, the number of estimated imported cases per NOTS 3 region increased by 600% within regions of Europe showing climatic suitability for dengue transmission. Okay, next slide, which is quite a significant increase. I think with that, I will hand it over to one of the next speakers. But before that, I want to thank all of our authors. Next slide. As well as all of the institutions that are collaborating to our report. Next slide. Thank you so much for listening. My apologies for the slightly awkward presentation and mess up of the slides, but you can find our results online if you scan this QR code, as well as follow us on Twitter. Thank you so much, and happy to answer any questions.
Okay, so I'm going to be talking a little bit about the Leishmaniasis indicator that we developed for the next report on the Lancet countdown in Europe. So then after my presentation, you will hear more about the whole report from Kim. So just a brief introduction about Leishmaniasis. Leishmaniasis is a vector-borne disease caused by a parasite, a protozoan parasite within the genus Leishmania. So we have multiple species of this Leishmania parasite, and it's transmitted by the bite of female infected sandflies. So sandflies they resemble mosquitoes, but they're not actually mosquitoes. They're a little bit smaller than mosquitoes. So they are the main vectors of Leishmaniasis. And there is also a very important transmission route between domestic dogs and other wild mammals as well. So the WHO estimates that over 1 billion people are currently at risk of Leishmaniasis infection in endemic area. And it is an extremely neglected disease worldwide. Regarding human transmission, there are several known risk factors. So most vulnerable populations are related to poverty, poor housing conditions, population mobility, malnutrition, weak immune systems. These are all factors that increase the risk of the transmission and the whole disease development in different settings. And yes, of course, the transmission is made through very ecologically complex transmission cycles, as we have multiple species of all of these, both the Leishmania parasite and the phlebotomine sandflies interacting in very complex settings. Regarding Europe, I always like to start with a sentence, remembering everyone that Leishmaniasis is endemic in Europe, but it's very much neglected. So it's not a very widely known vector-borne disease in Europe, especially because the case notification is not mandatory in most of the countries. We have very common underreporting, and it's very hard to estimate the actual burden of the disease. But according to this very nice and recent literature review on Leishmaniasis in Europe, the authors detected reports of Leishmaniasis in 22 countries and cited in the scientific literature. But then when you look at the disease reports in the WHO system, they only found that 17 countries reported those human cases. According to this review, in the period of 2005 to 2020, about 8,000 human Leishmaniasis cases were reported in Europe to the WHO, and this includes both clinical forms of the disease, which are the visceral Leishmaniasis and cutaneous Leishmaniasis. In addition to that, 8 European countries reported over 4,000 canine Leishmaniasis cases and 20 Leishmaniasis cases in wildlife to the World Organization on Animal Health. Regarding the sandflies, which are the vectors, they are widely distributed in Mediterranean countries, so this would not be the case of invasive species. So we already know that lots of sandfly species have their native distributions across Southern Europe mostly. The temperature limits the vector populations, and there are recent reports of northward geographical extension and into higher altitudes in Central Europe. So as part of the Lancet Countdown on Health and Climate Change, which Kim is going to talk to you about in a few minutes, for the next report, we were invited to develop a new indicator to track the climatic suitability for Leishmaniasis in Europe. And these came with a few challenges, which I'm going to be talking to you a little bit about. So perhaps the first challenge is finding good data regarding Leishmaniasis transmission in Europe. So luckily for us, the European Centers for Disease Control had recently released a report on the surveillance, prevention, and control of Leishmaniasis in European Union and its neighboring countries. So there is data there at subnational level for the period of 2009 and 2020 about the different NUTS3 regions within Europe which have or have not records of human or animal cases of Leishmaniasis called by Leishmanian phantom. So this was the data that we used to develop the Leishmaniasis indicator. Regarding the sandflies, also there is this amazing project by the ECDC, which is called VectorNet, where they periodically report the status of occurrence of different vector species across Europe. And they have these nice different categories where you can see here on the map, going from red to yellow to green, if the species are either present, introduced, or absent, or without known information within the different European countries. So this is the data that we use for the sandflies for the indicator. The whole modeling approach that we used, so the idea is to combine information from climate, land cover, and altitude. These data comes from satellite observations and different calibrated through weather stations in climate reanalysis data sets. We did a pre-processing of these variables, and then we are using these variables to first predict the climatic suitability for the vectors. So in this first step of the modeling approach, we fitted a machine learning model called XGBoost. It's a supervised classification model. Then we are combining this environmental and climatic information to first predict the suitability for the vectors. And then on a second stage, we use this climatic suitability for the vectors as predictors of human infections, human and animal infections, by adding another other set of climatic layers as well. And then in the end, we have the predictions of the climatic suitability for the Leishmaniasis in the different nuts tree regions in Europe. So these are the results that we are currently preparing for publication. They are going to be hopefully published in the report early next year. In the left side, you can see that we have the predicted suitability for the vector. So one thing that I didn't mention before is that we are working with 5 different potential species of potential vector species of Leishmaniasis in Europe. And then we combine this with the climate data to predict suitability for Leishmaniasis. And then the predicted output of the climatic suitability is associated with the current data that we have. So it agrees with the current distribution of the Leishmaniasis case in Europe, which are mostly present in southern, eastern, and western Europe at the moment. And then what we did, we predicted, or we used the climatic data to predict the climatic suitability for 2 decades. So we have a more recent decade on your right-hand side, which is from 2011 to 2020. And then we projected this into a previous decade, 2001 to 2010. By comparing these two time shots of the disease suitability in Europe, we developed this map that would be the main result of the indicator, which is the predicted change in suitability for Leishmaniasis. So what we see here on the map, on the different shades of pink, is that the different nuts tree regions that are colored with darker pink only became suitable for Leishmaniasis in the more recent period. So we can see that there is a progressive extension of the climatic suitability, or an increase of the climatic suitability for Leishmaniasis transmission in Europe. One thing that is interesting to see is in this map, the blue outline represent the countries that are considered today as endemic for Leishmaniasis by the WHO. So we see that some small climatic suitable regions are present outside of the current list of endemic countries. And when we look at the difference for stratified by countries, we can see that for some of them, we have an increase in the number of suitable nuts tree regions, such as Italy, France, Bulgaria, and North Macedonia. We can also see that for some other countries, they only acquire climatic suitability for Leishmaniasis in the second period, which is Slovenia, Serbia, Romania, Montenegro, Germany, and Austria. So just overall take-home messages from this quick presentation. Climate has become more suitable for Leishmaniasis in Europe in the last decades. The number of nuts tree region has increased in southern, western, and and Eastern Europe, while remaining absent from Northern Europe. Can't stress this well enough. Leishmaniasis is already endemic in Europe, but remains extremely neglected. And of course, the human population is not equally exposed to Leishmaniasis infection. We have different levels of vulnerability, and we are currently exploring these different inequalities in the Leishmaniasis risk across Europe. And we are also working on adapting the indicator to seasonal and subseasonal timescales. With that, I thank you for your attention. And this is largely, all of these results are largely part of this European Union funded projects called ID Alert and CLIMOS, which are part of the climate health cluster. Thank you very much for your attention, and I'll open for questions in the end of the session. So the next speaker is Giovanale, if you can start.
So thank you very much for having invited me. Today I'm talking about a project I conducted here in the Barcelona Supercomputing Center as a visiting postdoctoral researcher. The project was mainly focused on West Nile virus transmission in Europe. A short introduction to the pathogen and the disease. The West Nile virus is a mosquito-borne pathogen that can cause different clinical forms, usually can lead to a severe neurological syndrome in roughly 1% of infected subjects. And as you can see on the left, the virus is maintained in nature through an enzymatic cycle between mosquitoes and birds that act as a main reservoir. And humans are occasionally infected through a bite of an infected mosquito and are considered then and host. So basically they cannot transmit the disease to other humans. On the right, you see the clinical forms of the infection. Usually, roughly 80% of subjects they do not develop any symptoms, so are asymptomatic, while 20% they develop something similar to a flu syndrome known as West Nile fever, and 1% a severe neurological disease. It is important to also remember that we have this threshold of diagnosis. So the majority of infections that are diagnosed are neurological syndrome or West Nile fever, because they develop symptoms and so they are tested. In this study, I will focus only on the 1%, so on the neurological syndrome, assuming that the majority across Europe of West Nile neuroinvasive disease have been diagnosed. And the first outbreak in Europe occurred in 1996 in Romania. And since then, we observe a geographical expansion of the disease, usually with a marked seasonality during the summer, where the mosquitoes are active. And the major outbreak in Europe was observed in 2018 with more than 1,600 cases. And at the moment, the main areas interested in Europe are southern and eastern European areas, even if the virus has been detected already in birds and mosquitoes in other areas of Europe. The project was focused on understanding the relationship between two meteorological factors, precipitation and temperature, on the human infection. And this was mainly driven by the fact that we know that temperature affect the pathogen replication and the vector abundance, while precipitation we have hypothesis, even if it's less clear in the literature, that can both elevated precipitation or drought can influence the vector abundance. The majority of studies have been conducted mainly on vectors, and so the main hypothesis here was to study the relationship with human cases. So this study had two aims. The first one was to estimate an overall effect, an average effect across Europe of the short-term effect of these two meteorological factors on the incidence of neurological cases in Europe. And the second one was to check and understand potential heterogeneity of effect across different European countries. So concerning the methods, the data were obtained from the ECDC and were including all diagnosed cases of West Nile virus infection reported in Europe between 2013 and 2022. And this study, as I said before, was restricted to the neurological form that here is represented with the West Nile neuroinvasive disease, this acronym. And while metaclimatic data were obtained through climate reanalysis, mainly ERA5 land, and were obtained with a spatial resolution of roughly 9 kilometers per 9 kilometers for the entire period of study at a daily scale, and then were aggregated to weekly temperature and cumulative precipitation of different NATs that are the province of Europe. We'll see later. The study design that I adopted is known as a case crossover study design, and it is actually a study that is mainly used to understand short-term effects of exposure over an health outcome. So it's a study design that is being developed to evaluate, let's say, exposures that acts as acute trigger of events. Here is a schematic representation. So we observe, let's say we observe a case. In this case, is the West Nile virus infection, and what we do is we go and measure the level of an exposure, in this case precipitation and temperature, in a period that precedes the case, and we call it hazard period. And then what we do is we compare this exposure to other exposure that occur both before and after the cases. We call this a control period. So we sample other period across the time of the same individual, knowing that the subject was not a case in that period. And by matching, or mainly by comparing the exposure in the hazard period and the exposure in the control period, we can obtain a relative risk, so an estimate of an association between the exposure and the event. And this study design was adopted using a time-stratified sampling design. Is a specific sampling design, how to sample control period. Mainly, what you do is identifying control period within the same month of the case, and this is done to remove the seasonal effect. And this study design was applied together with these distributed lag nonlinear models in terms of statistical analysis. These models are models that can evaluate this lagged effect of a specific exposure. And as you can see, they produce these three-dimensional estimates. Over one axis, we have the lag. That means the time we measure the exposure preceding the event. On another dimension, we have the variable. In this case, would be temperature. And then on the y-axis, we have the outcome. In this case, are relative risk. So we can estimate how the risk of developing West Nile neuroinvasive disease increase as a function of the exposure, but also as a function of the lagged time. That means as a function of previous exposure. And this graph can be also analyzed and cut through different dimensions. We can collapse in a way these three-dimensional graphs to be represented as a two-dimensional. And I'm showing this because later you will see what I did, especially for the country-specific estimates, is fitting models centering the curve over the median of exposure. In this case, is the median exposure of temperature, and representing the relative risk of the 75th percentile of temperature. I'll explain you later. So these are the results. Here you can see the overall trend. As I said before, we had observed a huge epidemic in 2018 and another one in 2022. Here is the spatial distribution of cases. In the study period, we observe almost 3,500 neuroinvasive cases in Europe. And the 91.6% of these cases were reported by 5 countries. And this is why the analysis that I'll show you later, stratified by country, will be specific to these 5 countries where the power was enough to conduct statistical analysis. So, coming to the results, these are the 2 relationships estimated for temperature and rainfall, so temperature in red and precipitation in blue, in relation to the West Nile neuroinvasive disease. And as you can see, we observe a quite increase of risk concerning temperature observed 2 weeks before the diagnosis of the case. And for precipitation, we still observe a positive relationship that was mainly driven by precipitation, cumulative precipitation of the recorded between 2 and 4 weeks preceding the case. Now I'll show you the same graph, but cut through the lag dimension. And these are the 2 graphs. So this can be interpreted as which is the risk of being exposed to the 75th percentile of temperature compared to the 50th percentile. So an increase, mainly moving from a 50th percentile to the 75th percentile on the left for temperature, and the same for precipitation. And as you can see, with increasing temperature, we have an increased risk of West Nile neuroinvasive disease. And this effect, you can see over the x-axis, there are the lags, is mainly restricted to the 2 weeks preceding the diagnosis. So temperature associated with cases with a 2 weeks lag time. While precipitation, as you can see, have a more delayed effect, especially between 2 and 4 weeks preceding the diagnosis, and are more spread through across the whole lag period. In my case was between 1 and 8 weeks compared to temperature. And these are the results stratified by country. So the 5 countries that recorded the 91% of cases in Europe. So Greece, Hungary, Italy, Romania, and Serbia. And as you can see, relationships were mainly similar, I think, between countries. On the last graph, you can see the pooled estimate, that is an average of the 5 countries. And again, also stratifying by countries, we see that temperature have a main effect concerning short lag time, so mainly between 1 and 2 weeks preceding the case, while precipitation have a more diluted and delayed effects. So in conclusion, what we observe is that both temperature and precipitation recorded in the previous week before the diagnosis of neuroinvasive disease caused by West Nile are associated with the disease, and that precipitation have a more delayed effect. The highest relative risk here I report is observed at lag 3, so 3 weeks before, while for temperature is the highest one was observed at lag 2. And when pulling all the estimates across countries, we observe also that precipitation have a slightly higher heterogeneity, here reported as a I-square statistics, compared to temperature. So concluding, we can say that we could start using this information to build climate-informed early warning system, able to produce, in this case, given that we are focused on short-term effect, able to produce intra-seasonal forecast for the West Nile virus transmission. Many thanks.
Thank you, Giovanni. I think we're going straight to Rafael's presentation, and then we can have a group discussion at the end. The floor is yours, Rafael.
Thank you, Bruno. Hello, everyone. So it's a pleasure to be here presenting. So I'll talk a little bit about disease and climate data fusion for modeling. We just saw examples from that for the future works that was presented just now. And I'll give an application case example for Brazil as well. I have been already introduced, so I can skip this slide. So let's, I would like first to stress a little bit about the relationship between the climate and disease itself. Like the climate may have a direct relationship to disease, like on floods, droughts, heat waves. When the climate directly affects the human health, it's the situation that you can feel the weather and you feel the weather affecting your health directly. And also have an indirect relationship when the climate affects, for example, social and economic determinants of health, and then affects human health in the end. Also, the climate affects the conditions for disease vectors, and then the vectors that are spreading disease affects in the end the human health. I'll talk more about this case. We have the climate affecting the disease vectors, and then the human health. So it's necessary to investigate a little bit about the climate conditions that are necessary to vector viability and the efficiency to disease transmission. And in a modeling perspective, those climate indicators like temperature, rainfall, and others, they usually act as a proxy variable to vector distribution. The vector distribution, the infestation of a vector, for example, is usually more costly to have. The data is more hard to find, but if you have good climate indicators that are very well correlated to the vector distribution, they usually appear in the modeling, occupying this side of the equation. So that's why you see lots of studies predicting, for example, dengue and other climate-sensitive diseases using predictors, climate variables. It's important to remember, we just saw that this is a time lag relationship. So we need to put in the mind, to keep in mind that the vector life cycle plays a major role there in a time perspective. So the climate conditions from the past leads to the disease incidence of today and in the future. Just here in the picture, you have the Egyptian evolution. Takes from 7 to 10 days, but before that, prior to that, you have the climate conditions to act deposited in other places. So that affects a lot. If you have someone with the microphone open, if you can close it, it would be very thank you. So getting back. Climate data. So just saw how the climate data is important in the model. We have some data sources like weather stations, rain gauges, and satellites, like remote sensing. And it's important to differentiate data sources and data products. So from those data sources, we have data products like interpolations of indicators, like in the surface. We can have a temperature or rain surface, the distribution of the temperature, the distribution of rain over a territory. And we also have those model analysis. We just saw the RA5. That is a statistical model that creates predictions not to the future, but to the past. This is very interesting because with this kind of model, we can have very interesting data with good spatial and time resolution from decades ago. The RA5 example starts on the 50s. And we have data from the 50s with the same spatial and time resolution. it's very interesting to use it and to incorporate in the models. So talking a little bit more about the Era 5 length reanalysis from Copernicus. It has a global coverage with hourly data from hour to hour, starting in the 50s with 1 week lag around, and a spatial resolution of 9 kilometers near the equator, and presents several climate indicators that are very useful to study and predict climate-sensitive diseases. So let's think a little bit about the data structures that we have about climate and disease. The climate indicators are usually presented in aggregate data. As in the image on the left, the colors varies as the indicators goes up or down. Temperature is hotter or colder, but it's an aggregate format. You can imagine like a matrix of coordinates and values. And the disease data, like the disease incidence of a specific disease, is usually available as points, like we have the address of the case, or more commonly as a tabular data that we have the individual cases aggregated by spatial regions and specific time spans. So we have here the Latin America with some territorial boundaries, like municipalities, counties, or special divisions, like that. And we have the counts of a disease inside this boundary for a specific epidemiological week, for example. So that's the first challenge to model a climate-sensitive disease with climate data, because the data from the disease itself is usually aggregated in those spatial units, and the data from the climate indicators comes in a grid data format. It's not in the same spatial unit of the disease data. So there are some options to make those data comparable. One of them, to fuse these data, one of the methods available is to use zonal statistics. Like we have the municipal boundary here, and we have the grid file here with the values of the climate indicator. Then we need to overlay those two information, spatial overlay, and then do a spatial intersection. Select the cells that spatially intersects the boundary, and from the intersecting cells, we create some statistics, like what is the average value from the temperature in this municipality at that date. What's the minimum value? What's the maximum value? And then you can go on standard deviation, some values, and other zonal statistics to summarize the weather conditions that occur in the continuous space to a specific municipal boundaries, counties, and other regions, spatial units. So this is my case example to create zonal statistics of climate indicators to Brazilian municipalities using data from the Era 5 land from 1950 to 2022. So I used a little, selected some indicators, not all of them available on the Era 5, and computed those zonal statistics for the Brazilian municipalities. So a general overview of the method is to download the Era 5 land indicators inside a bounding box. So in this case, I select a Latin America bounding box covering Brazil and other countries. This data comes in an hourly data interval, Then you need to aggregate this by day. The hour interval is probably too much to study disease incidence, at least on the national level. Then we can aggregate this by a daily interval. And then with the municipal boundaries, you compute the zonal statistics from the methodology that are present in the illustration before. So we computed those statistics from 6 error 5 length indicators using some daily time aggregating functions, and then spatial zonal statistics. So we have a combination of indicators, the function that was used to aggregate the data in time, and the function that was used to aggregate the data in space. So you can have like the temperature, the average temperature, like here, or the maximum temperature, and the maximum value in the municipality, or the average maximum temperature in the municipality. You can have different combinations of that to try to summarize the climate conditions in a municipality. So this is just an example with the average temperature to the Brazilian capitals over time. So it's a lot. It's each line on each plot is one specific year, and we have the daily average temperature for those municipalities from the 1950 to 2022. And you can see different behaviors, even in the overall zoom of the graph. You can see the seasonality, the winter moments, or the range of values in Kelvin that we can have. And this graph could produce this graph to all the other indicators like temperature, beyond temperature, but precipitation and others. So this data is already available to the Brazilian municipalities with this time coverage from the 50s to 2022. So I think that the next steps are to update this data with the more recent data that's made available from the Era 5 products. The data comes every week. So it's like converting a product to a service to offer this data updated more often. Also to consider the human settlements of the territory, so we can weight the zonal statistics by the population. Like considering that there is no population living on certain areas, we can choose to not use the data from those cells and use only the data that has people living on. So this will be more specific to diseases that are related to urbanized areas, for example, like dengue. Also, with this kind of data, we can compute some climate time series features like heat waves, persistent rains, and other indicators from the time series of climate data. And also to extend these methodologies that I applied to Brazil to other countries. Also in the audience, lots of people from African countries and other regions. I think we can use the same methodology to offer this kind of data that's ready to use in modeling, statistical modeling, with the same spatial time units of the disease data. So thank you very much. I have my contact data links. The data is already available to download, and we are preparing a publication for that. It's available on the web link, and I'm available in the chat after the end of the event to questions. Thank you very much.
Thank you, Rafael. I think we're going to jump right next to Chloe for her presentation.
Hello, just one sec.
Hi.
And my screen. Can you see my slides okay?
Yes.
And hear me well, good. Okay, I'm not on mute this time, that's good. So hello everyone, for anybody who's joined a bit later, my name is Chloe Fletcher. I'm a PhD candidate in the Global Health Resilience Group at the Barcelona Supercomputing Center and in the Department for Medicine and Life Sciences at the Universitat Pompeu. So today I'll be talking about a collaborative project and multi-country study that we are leading at within the Global Health Resilience Group to forecast outbreaks of climate-sensitive infectious diseases in Latin America and the Caribbean in response to the current El Niño event. So this has involved developing statistical models to predict disease outbreaks using drivers related to climate and El Niño Southern Oscillation. So if you're not familiar with El Niño Southern Oscillation, it's a natural climate phenomenon that takes place in the tropical Pacific Ocean that is irregular every 2 to 7 years. This phenomenon affects global atmospheric circulation patterns, which subsequently impact climatic conditions such as temperature and precipitation in different parts of the world. So there are 3 different ENSO states. The most well-known is El Niño, which is represented by above average sea surface temperatures in the tropical Pacific Ocean, which often lead to increased temperatures and changes in precipitation patterns. We have its opposing state, La Niña, which is marked by below average sea surface temperatures, which often lead to decreased temperature as well as changes in precipitation. And lastly, we have the neutral state when there is neither an El Niño or a La Niña. And we typically trigger an El Niño event when the 3-month sea surface temperature anomaly in the region 3.4 exceeds 0.5 degrees Celsius. So we are currently experiencing an El Niño event, the onset of which was declared in July 2023. This image here shows the model predictions from the IRI of the current trajectory of the El Niño from October 2023. We're looking explicitly at modeling the 3-month average sea surface temperature anomaly in region 3.4 across a range of different dynamical and statistical climate models. And this is looking at predicting the peak of the El Niño. We can see that is approximately going to take place between November 2023, so this month, or potentially up to February 2024, depending on how the trajectory goes. However, despite potentially not yet reaching this peak, it's possible that recent anomalous climatic events may be attributed to this El Niño in some parts of the world already. Now, it's worth noting that the impacts of El Niño are not ubiquitous across the globe, and they can vary across different El Niño events. However, we can ascertain general teleconnections using historical climate data. For example, here is a map showing the correlation between the Niño 3.4 sea surface temperature anomaly averaged over December, January, and February, with mean temperature averaged on 3 monthly periods with lags of 0 to 5 months. So we can see initially that there is a strong warming that takes place, particularly in the north and western coast of Latin America and parts of Central America and the Caribbean. So very much El Niño is associated with strong warming in these parts of the world. And then when we look at a similar GIF for correlation with the mean temperature averaged over 3 months, where the blue represents increased dryness compared to normal and red increased wetness compared to normal, we can see the increase in dryness takes place particularly over the northern part of South America, with increased wetness located with Peru and Ecuador, as well as with Argentina, northern Argentina, southern Brazil, and Paraguay. So El Niño events in conjunction with climate change can increase the frequency, intensity, and unpredictability of extreme weather events, such as flooding, droughts, and storms. And there has been ample evidence showing the detrimental effects of extreme weather on human health, for example, through food insecurity, displacement, poor sanitation, and through the increased prevalence of vector-borne and waterborne diseases. Now, my colleagues in the Global Health Resilience Group have conducted various studies exploring the impact of El Niño and extreme climatic events on infectious disease risk within the Latin America and Caribbean region, including studies across Argentina, Barbados, Brazil, and Ecuador. And these studies have really demonstrated a strong association between extreme weather events and increased risk of the vector-borne disease dengue and waterborne disease leptospirosis. And such studies can be beneficial for understanding the climatic drivers of infectious disease risk, which can subsequently aid the development of decision support systems that provide early warnings of outbreaks and inform epidemic preparation. Now, for our study, we are looking to forecast infectious disease outbreaks across the Latin America and Caribbean region throughout the duration of this 2023 to 2024 El Niño event. And to do this, we will produce probabilistic forecasts for various climate-sensitive infectious diseases in areas of the Latin America and Caribbean region which are most impacted by El Niño Southern Oscillation, and host these forecasts on an operational platform. Now, the purpose of this is to provide a proof of concept for developing a climate-integrated early warning system which utilizes readily available climatic variables and Niño indices in a simple modeling framework. So we have been working to rapidly deploy a modeling pipeline, which could be subsequently applied to other regions in Latin America and the Caribbean, as well as in the globe, during a future El Niño event. And we will be hosting monthly forecasts with a 1 to 6 month outlook in each of our different case study sites throughout this El Niño event on an RShiny platform, with the hope to generate our first forecast towards the end of this month and retrospectively. Now we have 8 different locations to do our case studies, focusing on 3 climate-sensitive infectious diseases currently, including 2 vector-borne diseases, dengue and malaria, and the waterborne disease leptospirosis. Now, 4 of our models are more localized, so we have a model focusing in the north of Argentina, in the Brazilian Amazon, as well as the northeast and south hotspots of Brazil. And then we also have 4 national level models as well, focusing on Barbados, Colombia, Ecuador, and Peru. And we've selected these case studies based on a combination of strong El Niño teleconnections, as represented in those graphics previously, due to frequent outbreaks of these climate-sensitive diseases, as well as pre-existing relationships with local collaborators who have made this work possible in providing access to very much needed data, as well as helping understand our results through their localized expertise. So despite this year still ongoing, 2023 has recorded the highest number of dengue cases in the Latin America and Caribbean region than any other year, according to the Pan American Health Organization PLISA platform. Up to epidemiological week 45, there has been over 4.1 million cases of dengue, with some countries' counts yet to be declared on the platform, so this number is likely to increase. And this is 46% higher than 2022, which was the 3rd highest year on record, and is 29% higher than the highest year on record, which was 2019. And we have seen explosive outbreaks that have taken place across Peru, Colombia, Brazil, and Ecuador, amongst many others, and even prior to or toward the onset of the current El Niño, prompting concern over the evolution of the disease throughout this El Niño event, making our study even more pertinent. So for our research, we are using a simple Bayesian modeling framework to predict the probability of a disease outbreaks using up to 3 variables in any given models to try and keep the framework as simple and replicable as possible. So we are looking at 3 different variable categories, including temperature. So we're looking at monthly or 3-monthly averaged mean, minimum, and maximum temperature at a relevant spatial unit. So for many of our case studies, we're looking at like the administered level 2 or 1. And these temperature variables are lagged from 0 to 4 months. We are also looking at the monthly or 3-monthly mean temperature lagged at 0 to 4 months, and 4 different Niño indices, including Niño region 1+2, which sea surface temperature anomaly, which is the region most closely adjoining to Latin America, the Nino region 3.4 sea surface temperature anomaly, the oceanic Nino index, which is the 3-month average Nino 3.4 index, as well as the multivariate ENSO index version 2, which includes other parameters other than sea surface temperature, including sea level pressure, wind components, etc. And these Nino variables are lagged from 3 to 9 months within our modeling framework. Now, to identify the best model for each site and disease, we are fitting a range of different univariable, bivariable, and trivariable models using combinations of linear and non-linear terms. And to identify the best candidate models from several thousand models that we have assembled for each study site, we're using different goodness of fit metrics and visual inspection to identify up to 5 candidates before we decide our final model. Now, we are using, for our modeling framework, a Bayesian hierarchical mix model using the negative binomial likelihood to account for overdispersion in our disease data. And this enables us to fit up to 3 climatic and Nino variables, here is this X term, 2 disease instance rates from data provided by our local collaborators. Now, for each of these model runs, we've included spatial and temporal random effects to account for unknown variation within our disease data. And once we have selected our final disease prediction model, we'll be using seasonal climate forecast using up to 51 ensemble members from these forecasts in combination with climate observations, which would form, again, this X variable here, to extract each of the different parameters from our equation from 1,000 posterior samples to calculate the distribution mean of this negative binomial, and then therefore generate our posterior predictive distribution, which would have over 51,000 data points to reflect our 51 ensemble members and 1,000 posterior samples. Now, to assess the probability of an outbreak taking place, we would need to calculate what proportion of these 51,000 data points exceed an epidemic threshold. This epidemic threshold may vary from country to country, but in absence of a local standardized metric, we'll be using a moving monthly 75th percentile as this threshold. And then these proportions will be translated into different risk levels proposed here as low, medium, and high, which will be determined on a case-by-case basis. And this risk level should subsequently correspond to a national or local epidemic action to be valuable. Now, here is a proposed forecasting scheme. This is just an example here with a lagged Nino variable for 4 months, a temperature variable of 3 months, and a precipitation. You can't see that, I think my face cuts it off, but it's lagged at 2 months. And if we were to issue our 1 to 6 month outlook within November, we would have 6 target months spanning from December to May. In this first month, so in December, we could purely use observational data due to the lead time that our lagged variables provide. So, for example, because we have a lag of 4 months for the Nino, we can use observations in August, temperature observations in September, and precipitation observations in October. And then moving into January, as we would not have yet the observed data for November, as the month wouldn't have been completed, we would have to use observed forecasted precipitation for November, and that continues throughout the scheme as well, where eventually we need exclusively forecasts. And then if you look, for example, here in January, we can see as we move to this next month where we issue our next 6 forecasts, this the only thing that we would update within our forecast is this observed precipitation value, which would now be available. Again, this filters through to the following months as well. So that's our general scheme, and we hope to keep this operational platform available for the duration of the event and hopefully beyond to account for delayed impacts of El Niño. Just finishing up now, I'll just give a brief overview of the forecasting platform. We hope to host on this historical, climatic, and disease data, model verification via our cross-validation process, as well as the 1 to 6 month forecast for each of these study sites. So each of the different countries will have its own individual secure page, which will be made clickable upon that map or that drop-down. and that will be made available only to relevant people within that country due to the sensitivity of the data, particularly the disease data. However, we hope to publish our results and comprehensive methodology sometime next year, as well as evaluate the efficacy of the forecasting system in each of the different study sites to see how well this could be applied in a future El Niño event. I just want to say a special thank you to all of our collaborators who have made this work possible, particularly in providing data and expertise. So we're very grateful for that support. And lastly, thank you very much for your time and happy to take questions.
Well, thank you so much to the Barcelona Supercomputing Center's teams. That's been an amazing session. It's been packed with so many projects across lots of different diseases, but also resources and tools, methodologies. I'm sure you've given everyone listening in lots of food for thought. I do think an hour and a half was never going to do justice to the incredible body of work that you are doing across climate and health. And as we do have a few minutes for questions, I would like to perhaps bring all those projects that we've heard about in the last hour or so together with this one kind of question about, on the one hand, we keep hearing very loud and clear this message about the urgency with which climate change must be understood and tackled. And then on the other hand, we're also hearing about a lot of data gaps that remain and hinder that sort of progress to understand, predict, remedy any climate-driven consequences on diseases. And particularly in neglected tropical diseases, despite an uptick in research to understand those dynamics, and we will be hearing about that a lot more in the next session, there are still a lot of gaps remaining in the research and building that evidence base. So at the Barcelona Supercomputing Center, you have been very successful at achieving these wide ranges of research and collaboration. So given sort of all those challenges, what would your final words or what would your advice be to any researchers or health professionals who do want to add to that evidence base? Where should they start? Vast question, but any practical tips that our audience can take home with them? And perhaps I'll just go in order of the presentations, please. Bruno, would you like to go first?
Yes, very nice question and tough one. I don't think there's an easy, straightforward answer to that one. But I guess from the researcher's perspective, I think we are in a point where collaborative research is growing up a lot. And we have a lot of tools for interacting and communicating across the globe. So it's a fairly good timing to develop not only your own personal research skills, but also reaching out to different teams in different settings. And this way, our group is fairly open to collaborating and helping people achieve those goals. In terms of research, so people interested in taking master's or PhD courses can also reach out to us, or even to at a more senior stage, being part of collaborations in different research proposals. So I think interdisciplinarity is key, and fostering these types of collaboration, I think, could be very useful to tackle these research challenges.
Thank you so much. Kim, at the Lancet Countdown, it's all about the collaborations that Bruno just mentioned across so many institutions and partners. What would be your view or advice?
Something similar to what Bruno said. I think mostly interdisciplinary collaboration is key. Working with climate scientists, working with social scientists, because I think it's difficult to have the expertise in everything, but if you work with all the people that have the expertise together, you can create the insights that we're looking for. And particularly when I look at the Lancet countdown and the work we are doing, we're currently missing a lot of data on vulnerable groups and inequalities and justice. So we need to interact a lot more with social scientists as well. So I think interdisciplinary collaboration is something that I see as a key thing for the future.
Brilliant. Thank you so much. Giovanale and Raphael, you were really at that juncture of the data from a more of a data perspective. What would be your advice?
Well, what I can say is that coming from let's say an health field, I wouldn't be scared about climatic data, because now we have a lot of tools to measure it, climate reanalysis, satellite data, land-based observation. We have experts, so we can collaborate with them. So coming from an epidemiological perspective, I wouldn't be scared of this part. It's just an opportunity we need to take it to reach an interdisciplinarity perspective. So this is my main suggestion as an epidemiologist coming from the more medical world.
Fantastic.
Yeah, I agree with Giovanale and the others. It's a very interdisciplinary field. So even for data collection, ask for help from data engineers, from computer science, that can help you start projects to gather all the data, and then you can focus on your research objective. And as a final point, always, when possible, try to share your data as well. Share your methodology, share your data. We use a lot of open data sources, and it's very important to keep the secondary data that comes from those data sources, to keep them open as well, the research methodology and everything, to be reproducible on other countries, on other places.
Wonderful. And Chloe, over to you.
I mean, I agree with all my colleagues on this as well. Coming from the opposite perspective, actually, to Giovanale, I come from a climate background and have recently moved into health and climate over the last year and a half. And I would also agree from that other side to not be too daunted by moving more towards an epidemiological space. I mean, there is so much you can learn from the literature, from engaging with many experts from across the field, both in person, if possible, but also from online engagement or webinars such as this. It can be very valuable. And I would also say, from my perspective, my work is very much focused in developing early warning systems. I feel one of the key things that we should take away is the idea of co-creation and co-development with local practitioners, indigenous leaders, if possible, and so on. So really actively engaging and listening to local communities that are personally impacted by these diseases, I would say, is very valuable.
Thank you so much. And I think that the neglected tropical diseases field is good at that, or certainly has that center of a lot of their activities already. Thank you so much for reassuring everyone to overcome their fear of bringing together climate and health data. You've given us so many practical tools, and what's very evident is your unified message of get in touch, seek out partnerships. If you have a question, if you're looking for help, reach out. So I think that will be very reassuring to many who no doubt are really interested in linking climate and health in their work. We've heard a lot about data and modeling in this session. Thank you so much for everything you've brought to it. We will soon be moving over to our next session, which is going to look a bit more closely at the evidence base, drawing on examples from yellow fever and snakebite and echinococosis, but also with a very interesting presentation about what gaps are remaining, what are the major gaps in climate and health research, climate and health modeling. So please do join us in the next 15 minutes after a short break to hear a lot more about that. And I'm just going to post the link to the next session. But until then, again, a really, really massive thank you from all of us. A thank you to our audience as well. who's been very engaged in the chat, asking lots of questions. I'm sure you've given us a lot of things to think about. And so from ISNTD to the Barcelona Supercomputing Center, a final big thank you. And we will definitely keep in touch and follow your varied, numerous, exciting projects. And we hope to meet again very soon.
Thank you very much, Marianne.
Thank you so much.
Thank you.
To our audience, see you in about 15 minutes in the next session. All the best to everyone.